Hello, everybody, and welcome to our first webinar of the fall series on osteoporosis. And Dr. Kelly Hedgepeth and I are so excited to welcome Dr. Sharon Chou. She's an endocrinologist at Brigham and Women's Hospital. She did her internal medicine residency training at Beth Israel and her endocrinology fellowship at University of Chicago, and has now been on staff at Brigham and Women's and Harvard Medical School, where I think a lot of you actually are her patients. I know that she has an extremely busy practice, both at Brigham and at Foxborough, largely taking care of patients with osteoporosis. So we're really lucky to have her here to answer all of our questions. I know some of you submitted questions ahead of time, and we're going to put those in the chat. So keep an eye on the Q&A in the chat. And as Dr. Chou's talk progresses, she's going to save time at the end, as we always do, for more questions. Feel free to add more questions into the chat. So Dr. Chou, welcome, and thank you so much for being here.
Thank you so much for having me. I'm really excited to be here to give this talk today. This is my first patient webinar, so be easy on me. But I think I have a lot of good information for you guys, and then I left plenty of time at the end for any questions. So I am just going to go ahead and share my screen here. Okay, excellent. So today's topic, as we had alluded to, is about osteoporosis and bone health. And I just want to start with a definition of osteoporosis. So osteoporosis is defined as a skeletal disorder characterized by poor bone strength. But what we're ultimately concerned about is the risk of fracture. So you can see here, I have x-rays of two very common osteoporotic fractures. One is a hip fracture here that's been surgically repaired. And in this image here, this is the side view of the spine. And you can see in this particular patient, there's been multiple compression fractures all along their spine, causing this curvature of their spine. So in fact, this is probably the only vertebrae in the spine that is not fractured, whereas you can see the other vertebrae are compressed or fractured. So why is osteoporosis important? First of all, it's extremely common. So 54 million Americans have either osteoporosis or osteopenia, which is sort of like pre-osteoporosis. And we know that 1 out of 2 Caucasian women and 1 out of 4 men will have an osteoporotic fracture in their lifetime. And if you can see here, if you add up all the osteoporotic fractures, they far exceed the number of patients with strokes, heart attacks, and breast cancer. Why else is osteoporosis important? Well, these fractures lead to loss of independence. So after a hip fracture, 40 to 60% of patients have decreased mobility, 30 to 60% become dependent for basic activities of daily living. And what's probably the scariest thing of all is that 10 to 20% end up in long-term nursing facilities. That last one is a good motivator to help protect our bones there. And you can also see that fractures lead to premature death. So for women, after a hip fractures, there's 20% excess mortality in that first year, and even more in those in men who've had fractures of the hip. And what's most important of all is that these fractures can be prevented. So zoledronic acid is a commonly prescribed medication for osteoporosis. And you can see here, after 1 year of treatment, the risk of vertebral fractures already decreases by 60%. And then over 3 years, the risk of vertebral fractures decreases by 70%. So how do we diagnose osteoporosis? So we use a radiology tool called a DEXA machine to measure the bone density. And you can see here that this is a pretty typical DEXA machine back here. So it's open to the air, not like an MRI, and it shouldn't be claustrophobic or anything like that. It takes about 20 minutes, and there's very minimal radiation involved. So it's about the same amount of radiation as 1/20th of a chest X-ray. And when we do a DEXA scan, we usually do it at the spine and the hip. And again, these are sites of major osteoporotic fractures. So we do want to know what the bone density is at the spine and at the hip. And in some particular patients, we'll also do a scan at the forearm. We will typically do a bone density scan at the forearm if we're not able to get a good picture of either the spine, either because of osteoporosis or history of spinal surgery, or if we're not able to get the bone density at the hip. For example, some patients have bilateral hip replacements. And in that case, we'll do a bone density scan at the spine and the forearm. And there are also certain medical reasons to get bone density at the forearm. So these are patients with primary hyperparathyroidism. In that particular disorder, we tend to lose more bone at the forearm. So that's where we want to monitor the bone density in those cases. And sometimes I'll have patients ask me, can I get a bone density elsewhere in the body? The problem with getting bone densities done elsewhere in the body is that we don't have a good reference range for that. So we have a reference range for what's normal at the spine, the hip, and the forearm, but we really don't have good data on the other sites. And just backing up a little bit and giving some background information on how our bone density changes with age. As you can see here, I'll track along the females for now. As we're younger, we're building up our bone density until we hit about 20. And then we sort of, between 20 and 30, that's when we reach as much bone density as we're ever going to reach. So that's called your peak bone density. And then while women are at least premenopausal, it's pretty stable until we hit menopause. And once we hit menopause, we lose bone at a pretty rapid rate, about 1 to 2% per year on average. And that lasts for about 5 to 10 years before it slowly, gradually shifts down to the 0.5 to 1% per year in our older age. And so for men, they are less likely to have osteoporosis because they get more peak bone mass to begin with. And then they tend to lose slowly, get the 0.5 to 1% per year. And they don't experience the rapid loss that women do. So when you get a bone density report, there tends to be 3 different numbers. So again, here is an example of a report with the bone density performed at the spine and at the hip. And there's 2 areas of the hip. There's the total hip, and then there's the neck of the hip. And the bone density is the raw score. And then the T-score is comparing your bone density to a healthy 30-year-old. And again, we want to compare it to a healthy 30-year-old because that's when we reach the most bone. So these numbers here are the standard deviations from an average 30-year-old. And then you can say, wait, that's not quite fair. I'm not 30 years old anymore. How do I compare to my own age group? And so that is the Z-score. So the Z-score compares you to your own age group. So for example, this is a bone density report for a 65-year-old woman. So if we look at the spine T-score, that's -2.8. So compared to 30-year-olds, she's right about here where most 30-year-olds will have more bone than she does, which makes sense. And if we look at the Z-score, so compared to her own age group, you can see she's right here for her age group, and it's considered completely normal for her age group. And so that's just saying that a lot of people who are 65 years old will normally have osteoporosis or osteopenia. So once again, the T-score compares your bone density to a healthy 30-year-old, and that's what we use to diagnose osteoporosis in postmenopausal men and women, postmenopausal women and many men 50 and older. And again, the Z-score compares you to your own age group. And so we use the T-scores to determine who has osteoporosis. So normal is considered to be a T-score of -1.0 or above. And this would be an example of a patient with a normal bone density. Osteopenia would be a T-score between -1.0 and -2.5. And then osteoporosis would be a T-score of -2.5 or below, or 2.5 standard deviations below a healthy 30-year-old. And here's a representation of what that would look like. So there's other ways to be diagnosed with osteoporosis. So one way was the T-score that we just reviewed. The other way is to see if you've had a history of fractures in the past, because ultimately, remember, osteoporosis just means that you're at a higher risk for fracture. So if you've had a spine fracture or a hip fracture from a trauma that's the equivalent of a fall from a standing height, you've already proven to yourself that you're a high risk for a fracture since it's already happened, and you're considered to have osteoporosis regardless of what your bone density is. Because ultimately, again, what we care about the most is that you're fracturing and not what a number is on a bone density test. Similarly, if you've had a fracture of the shoulder, the pelvis, or wrist, plus your bone density is in the osteopenia range, we would also consider you to have osteoporosis. So you're at a higher risk for fractures, as you've been shown to already have it. There's other ways to determine if your fracture risk is high. One way is to use a fracture risk calculator, such as the FRAX tool. This is probably the most commonly used tool we have. And you can go online and I usually just Google FRAX and it'll pop up. And you'll put in all your risk factors, and then it will give you a score. And what it'll give you is a 10-year risk for a major osteoporotic fracture or a 10-year risk for a hip fracture. And if your risk of a major osteoporotic fracture is 20% or greater, or your risk of a hip fracture is 3% or greater, then you're felt to be at high risk for fracture and should consider treatment. And just keep in mind that most women with hip fractures actually only have osteopenia. Just because there's so many more women with osteopenia than osteoporosis, that most of the women with hip fractures only have osteopenia and have not yet progressed to osteoporosis. So this is a screenshot of what the FRAX fracture risk assessment tool calculator looks like. So you'll put in your age, your sex, your weight, and height, whether or not you've had a previous fracture. This is considered an adult fracture that most adults would not have had given the same amount of trauma. If your parents have ever had a hip fracture, if you're currently smoking, if you've been on medications like prednisone or other steroids in the past, usually for 3 months or longer, if you have a history of rheumatoid arthritis, if you have any other reason to have osteoporosis, such as celiac disease, if you have more than 3 drinks or more per day, and then you can also put in your femoral neck bone density. And then it'll calculate out your fracture risk. So who should get a bone density scan? So it is recommended that all women 65 years and older have a screening bone density scan, and men 70 years and older. And there are younger women who should also consider getting an bone density scan. So those would be any postmenopausal woman with history of fracture, and then postmenopausal women taking any steroid medications like prednisone, because prednisone has a particular effect on the bone that does increase the risk of bone loss and fractures, particularly spinal fractures. And then there's other peri or postmenopausal women with certain risk factors that may want to consider getting a screening bone density scan earlier than 65 years old. And that includes if you have low body weight, so you're 127 pounds or less, or a BMI of less than 20. If there's a family history of osteoporotic fracture, if you've had early menopause, so earlier than 40, or in the early 40s, and then if you're a current smoker or have excessive alcohol use. So how can we prevent osteoporosis? So adequate calcium and vitamin D is important to help with the bone health. So the research studies have shown that calcium supplementation alone or vitamin D supplementation alone really does not reduce your fracture risk. And part of that is how calcium and vitamin D work. So your bones need calcium, and your vitamin D help your gut absorb calcium. So you really need both for it to have an effect on your bones. And so what we have seen is that research studies that use both calcium and vitamin D do modestly reduce your risk of fracture. So up to 30% at the hip and 15% for all total fractures. And what I recommend is that my patients get enough calcium to meet the Institute of Medicine guidelines. So for women 51 to 70 years old, basically postmenopausal women up to the age of 10, any postmenopausal woman, to get 1,200 milligrams per day of calcium. And then for men, because they don't get osteoporosis as early as women do, 51 to 70, a goal of 1,000 milligrams per day, and then greater than 70 will be 1,200 milligrams per day. So how do we get enough calcium? So we want, so when we say 1,200 milligrams per day, that's from diet and supplements combined. If you have a lot of calcium from your diet, you would not need any calcium supplementation, but it can be hard to get enough calcium from your diet. A quick way to think about it is to get 3 to 4 servings of dairy per day. 1 serving of dairy is about 300 milligrams of calcium. And so if you get 3 servings of dairy per day, that's 900 milligrams of calcium. And most people get another 200 and 300 milligrams from their non-dairy foods throughout the day. And so I've put in a list of foods that are high in calcium. So 1 cup of milk, 1 cup of yogurt, or 1.5 ounces of hard cheese will give you about 300 milligrams of calcium per serving. Now, in order to get that from vegetables, you would need 3 cups of kale or 10 cups of spinach or 10 cups of broccoli. So it's really hard to get all your calcium needs from non-dairy foods. Tofu is a good source of tofu is a good source of calcium, but it's not the most appetizing thing. And I don't know if you want to take that on a daily basis. And then you can see here are some other foods that are high in calcium, though you might not necessarily want to get all your calcium from those foods as well. So I typically tell my patients, if you're able to get 3 to 4 servings of dairy per day, you don't need to take any calcium supplements. If you get 1 to 2 servings of dairy, then you can take a calcium supplement of 500, 600 milligrams. And then if you can't tolerate any dairy at all, I would just take a calcium supplement, 500 to 600 milligrams twice a day. And you really want to split the calcium supplement up between, so it's twice a day instead of 1,200 milligrams all at once, because if you take 1,200 milligrams all at once, it really does overwhelm your kidneys and you end up urinating out the extra calcium. So you're really not getting that extra calcium. There are some calcium supplements that are slow release formula, and those you can take all together at once. It may be more convenient, because sometimes it is difficult to take something twice a day. And then I get a lot of questions about which type of calcium supplement is the best. So in general, if you're not taking heartburn medications like omeprazole or famotidine, such as Pepcid, you can take any calcium supplement, either calcium carbonate or calcium citrate. But if you are taking heartburn medications like omeprazole, then you should take calcium citrate, because that will be better absorbed than calcium carbonate. So calcium carbonate requires acid in the stomach for absorption, and calcium citrate does not. And over the years, there has been some concerns about calcium intake leading to a higher risk of cardiovascular events. The most recent research shows that as long as you're getting less than 2,000 milligrams of calcium per day, either from food or supplements, that is considered safe from a cardiovascular and cerebrovascular standpoint. And all I need is 1,200 milligrams. I don't need 2,000 milligrams per day. What about vitamin D? In the media in the last few months, there's been a lot of questions about vitamin D. So out of our division of endocrinology here, we did recently publish in the New England Journal of Medicine the results of a 5-year trial of vitamin D, 2,000 units per day, showing no benefit in terms of fracture reduction in the general population. So again, remember what I said, usually a lot of the studies with just vitamin D supplementation or just calcium supplementation really haven't been shown to help the bones at all. What I do want to point out is that this was a very large study of 25,000 participants, and these were from the general population. So they weren't selected because of any bone density criteria at all. And what we do want to say that, we can't use this data for our patients with osteoporosis. So for my patients with osteoporosis, I still recommend getting enough vitamin D as well as calcium. And in my practice, I check a 25-OHD blood test to make sure that your vitamin D level is between 30 and 50 nanograms per milliliter. And then exercise. So I'm sure you've heard that weight-bearing exercise is the best for your bones. And what is weight-bearing? Weight-bearing is just anything on your feet. So walking, and there was one study that suggested that 10,000 steps per day may be beneficial. Hiking, dancing, stair climbing, all this is great. Playing tennis, and I know pickleball is big these years. So any of that is considered weight-bearing. If you do have severe osteoporosis, you should avoid bending and twisting of the spine and heavy lifting, because that could cause a vertebral fracture. So if you have any concern about any restrictions on exercise, just ask your primary care doctor or your specialist. But in addition to weight bearing, strength training is also very important for your bones. So strength training can run the spectrum, starting from exercises, simple exercises for posture and balance that don't require any hand weights or any weights at all. And then for the more advanced, not advanced, but for other patients, who are more athletic, there are also particular high intensity resistance and impact training that has been shown in clinical trials to improve bone density, particularly at the spine. And in this particular program, they did things like deadlifts, overhead presses, and back squats with weights, and they were able to improve their bone density of the spine. This program was an 8-month program in Australia, supervised by personal physical trainers. And so it's not anything that I recommend my patients do on their own, but under the supervision of a trainer, because you don't want to accidentally injure yourself by doing something incorrectly. You do need to have the correct technique. Other lifestyle recommendations, if you are a smoker, we do recommend that you quit smoking, and to limit your alcohol to 2 drinks or less per day, limiting the caffeine intake to 1 to 2 servings, less than 1 to 2 servings per day. And I do have a lot of patients who take magnesium and vitamin K and other supplements. And what I will say about these other supplements is there really isn't a lot of good data that show that these other supplements reduce fracture risk. So in most cases, it probably doesn't hurt, but it really hasn't been shown to reduce fractures. And ultimately, again, that's what we're trying to do, is reduce your risk of fractures. And then fall prevention is the other important aspect of fracture prevention, because most fractures happen after a fall. And so some ways to prevent falls is participating in a physical therapy program, reducing home hazards by anchoring rugs, minimizing clutters, installing handrails, particularly in bathrooms, making sure that hallways and stairwells are well lit, having proper footwear, and then having your eyes checked. And then I do have patients who come back to me and say, I've done everything, I'm getting enough calcium, I'm getting enough vitamin D, I'm doing all this exercise, and I still got osteoporosis. Why? Why do I still have osteoporosis? And I just tell them to keep in mind that, as every year we get older, our bone density is expected on average to go down 0.5 to 1%, even with everything else going on. So I don't see it as a failure or anything like that. I just see it as an aging process here. So when should we start osteoporosis medications? So in general, I will recommend patients start osteoporosis medication if they've had, again, that hip or spine fracture from a fall or trauma equivalent to a fall. If their bone density is in the osteoporosis range at the spine, the total hip, or the femoral neck, or if they have any other indication that they're at high risk for fracture. For example, if their FRAX score is elevated, so their 10-year risk of major osteoporotic fracture or hip fracture is high. And there are a lot of options for osteoporosis treatment these days. So there are two main categories of osteoporosis medications. Most patients take medications in this category. So these are medications that slow down the breakdown of pill. And these, for example, can be a daily pill, which is raloxifene. So raloxifene acts like estrogen in certain parts of the body. So it acts like estrogen at the bones to help protect the bones. The nice thing about raloxifene is it acts like an anti-estrogen at the breast and can reduce the risk of invasive breast cancer. So that is a good option for patients who have a history of breast cancer or a family history of breast cancer and are also worried about breast cancer risk. Most patients are probably taking oral bisphosphonates. These are medications like alendronate or risedronate, and they're usually a pill once a week, or the risedronate also comes as a pill once a month. And then for patients who have heartburn, zoledronic acid or zoledronate is also a good option. This is an IV bisphosphonate that's very convenient to take. It's only once a year. And then we also have denosumab or Prolia, and these are injections that are administered every 6 months. So again, these are the medications that slow down the breakdown of bone. And then we have medications that help stimulate new bone growth. So these are really good medications for patients who've already had major osteoporotic fractures, particularly vertebral fractures, because all three of these medications are very good at preventing vertebral fractures. Or if your bone density is very low, particularly at spine, so if your T-score is below -3.0, then you might want to consider starting with a medication to help build new bone first. And these are medications like abaloparatide or teriparatide, which are daily injections that we would teach you to give yourself. And then the newest medication we have on the market is romosozumab or Evenity. And that's a monthly injection for 12 months that actually does both. So it actually builds new, fresh bone and slows down the breakdown of bone at the same time. And you can see here that these osteoporosis medications are very effective at preventing fractures. So raloxifene reduces spine fractures about 40% compared to placebo. And then alendronate reduces spine and hip fractures about 40 to 50%. Zoledronate, the IV bisphosphonate, reduces spine fractures generally 70% over 3 years and 40% hip fracture reduction over 3 years, similar to denosumab. And then you can see here abaloparatide, our bone building medication, is extremely effective at reducing vertebral fractures and reduces vertebral fractures by 86% within just 18 months of treatment compared to placebo. And of course, I have a lot of patients who bring up these complications of these medications. So medications like bisphosphonates, the once a week or once a month pills, alendronate, risedronate, and the IV bisphosphonate zoledronic acid, and the Prolia injections do have these very, very rare complications. One is the osteonecrosis of the jaw. Osteonecrosis of the jaw is defined as exposure of the jawbone for more than 8 weeks. So you can see here, right here is where the bone is exposed. It's usually triggered after a tooth extraction or a dental implant. And what I tell my patients is that they're extremely, extremely rare with the pills. So with the pills, generally your dentist will ask if you're taking any of these medications and you say, oh, you are, and they have you stop it for a couple months. Which is absolutely fine for me. There's a slightly higher risk with the IV infusion, the zoledronic acid infusion, or the denosumab injections, but the overall risk is still 0.05%, so extremely low. Osteonecrosis of the jaw is mostly seen in cancer patients who are getting much higher and more frequent dosing of the zoledronic acid infusions. So they can get the infusion pretty much every single month. And so you can see how they're getting a much higher dose of the medication. Most of the cases of osteoporosis of jaw are treated conservatively with just antibiotic rinses and time. Okay. And then there's absolutely no issues with cleanings, fillings, crown work, or even root canals. And overall, the American Dental Association and the American Association of Oral and Maxillofacial Surgeons do not recommend routine discontinuation of the bisphosphonates in most patients prior to dental procedures. They may ask you if you've been on it for 4 years or more, or if you're on steroids such as prednisone at the same time. And generally, I'll have dentists, even if you don't meet that criteria, to stop the pills for a short duration time. And I generally don't have any issues with that at all. The other rare complication are these femur fractures, these atypical femur fractures. And again, they're extremely, extremely rare, but they do, the risk does increase with prolonged use of these medications like the alendronate or the zoledronic acid. It usually starts as a stress reaction in the bone, and then it can progress to a stress fracture and then a full fracture across the femur. And you can see here in this graph how likely it is to happen. So most patients are treated with alendronate or risedronate for about 5 years. And in this graph, you can see with 5 years of bisphosphonate medications, such as alendronate or risedronate, for every 8 atypical femur fractures that occur in these participants, 286 hip fractures are prevented, and 859 clinical fractures are prevented. So you can see here that the benefit, the prevention of fractures, really outweigh the small fraction of patients who get these femur fractures. But it is a concern of mine. And so I do keep track of how long my patients have been on these medications. And I do make sure that they have sufficient drug holidays built into their program. And the part of the reason for the drug holidays is that the risk of these atypical femur fractures do decrease 70% per year after stopping these medications. So as long as you have time off in between your courses of bisphosphonates, the risk of these atypical femur fractures remain extremely, extremely low. And keep in mind, I tell my patients, keep in mind that the goal for osteoporosis treatment is so that you can stay active, enjoy your retirement, travel around the world or wherever you want to go, play with your grandchildren, and of course, most importantly, stay independent. So in summary, fractures are common, especially with older age, and are extremely debilitating. A bone density scan can help determine your fracture risk. Getting enough calcium, vitamin D, and exercise may help keep your bones healthy. Though when we need to, we have very effective and safe medications that can prevent fractures. So I can stop here and open this up to any questions.
Oh, Sharon, that was fantastic. I think of all the questions that had been submitted ahead of time, you already answered quite a few of them, and more are coming in. So one thing you didn't mention is the role of estrogen. So you did say that after menopause, for women, that's when bone strength and bone density starts to decline fairly precipitously. Therefore, does it make sense that we should consider estrogen replacement therapy for women, especially those with osteopenia or who are at high risk?
Absolutely. So I do offer my patients hormone replacement therapy as a treatment option for osteopenia, osteoporosis. Generally, these are women who have recently gone through menopause or going through menopause, generally having other menopausal symptoms such as hot flashes in particular. And what I tell my patients is we feel pretty comfortable using hormone replacement therapy up till the age about 60, and then we really want to reassess the risk and benefits. The main concern, the main risk for me is just breast cancer risk. So we do know that hormone replacement therapy does increase breast cancer risk even after we've stopped the hormone replacement therapy. So there are some calculators out there similar to the FRAX calculator that can help calculate your risk of a breast cancer, kind of determine whether or not you'd be willing to accept that risk or not. And then in the past, after the Women's Health Initiative, we were worried about higher risks of heart attacks and strokes, but that seems to be mostly in patients who have been out of menopause for more than 10 years and then starting hormone replacement therapy at that time.
Yep.
So if you start it close after menopause, that generally doesn't seem to be a factor anymore.
Yes, that's true. So for us as cardiologists, we do not object to hormone replacement therapy when there's a good indication for it. As far as if you're more than 10 years out, it can increase cardiac risk.
Absolutely.
And is the mechanism of estrogen that it slows bone loss, or does it actually build new bone?
It mostly slows bone loss. So how I think about it is that you're basically postponing menopause. So, and so then once you stop hormone replacement therapy, again, you would expect to have that rapid drop in your bone density.
Okay. So for several reasons, you wouldn't necessarily suggest it more than 5 or 10 years after menopause. One being that the risks go up.
Correct.
And the benefits go down. And so then those other factors come into play. Okay. Thank you. Very helpful.
And can I just jump in here? Sharon, this is such a great talk. And there's a lot of questions that have even repeated some of the things you've gone over. So we might have to just double back and have you repeat some things, because I think
no problem.
There's a lot of layers to the complexity that you talked about. But when you were talking about estrogen, there were some questions in the chat about seeing an impact on your DEXA scan. So when you're talking about therapies and HRT being one of them, should women expect to see an improvement or a stabilization, or how do you think about that?
So, so for HRT, I usually do see a slight improvement in bone density, but it's usually after that first 1 or 2 years, and it sort of plateaus and it doesn't continually go up. But then, even if the bone density just remains stable, I'm pretty happy with that outcome as well. I just don't like to see it if it continues to go down despite hormone replacement therapy.
You talked about a drug holiday. So if someone's been on something like alendronate or Fosamax for years and then stops it, how long does that holiday last for? When do you recommend starting again?
That's a very good question. So one of the nice benefits of alendronate is that if you take it for 5 years and you stop, you're still protected against fractures for at least another 5 years or so. Most patients are. And so during that time, what I like to do is keep an eye on your bone density every, 1 to 2 years, depending on any risk factors. And what I tell my patients is that as long as your bone density is stable, as long as you're not breaking any bones, I tend to continue the drug holiday. But at some point, I would expect it, to need the medication again. And either you can go back on the alendronate if you did well with it before, or you can pick a different medication.
Great.
So there are a couple of questions just to elaborate on bone strength versus the density, right? And I mean, when I go through exercise for cardiac reasons with my patients, right, I try to just, explain how every system in your body has this positive effect of exercise, right?
Absolutely.
And all your muscles are hooked to your bones, right? So exercise does affect your bones, and bones are really dynamic, right? And are active live cells. So how do you think about, just the bone in terms of what it is and, this living thing and how we can impact it?
Absolutely. So I think you mentioned a few things here. So we do know that bone strength depends on both bone density and then the quality of the bone. And, it's about 50% for each. And so the bone density, that's pretty easy to measure. You get a DEXA scan, you have a number for your bone density. Bone quality is not as easy to measure. And that's sort of our other bucket. Anything else outside of bone density, we just throw into the bone quality bucket. And those are things like the microarchitecture of the bone that we can't quite capture on the bone density test, how quickly your bones are turning over, so how quickly your bones are breaking down and rebuilding, the quality of the collagen, and other things that are much, much harder to measure. And there's lots of research into looking into how we can best measure these things, but nothing that's been rolled out on a large patient scale level. So that's one thing. So a lot of patients will say, my bone density looks pretty good, but I have all these fractures. So then, I would say, let's focus on the fractures, because ultimately that's what we care about, is your fracture risk and not your bone density score. And then, yes, bone is absolutely a dynamic organ. So it's not this like piece of calcium that's in our bones that doesn't do anything. And so our bones are very active. They're actually always breaking down and rebuilding. So that's the remodeling process of our bones after the age of 30. The problem is every time our bones break down, it doesn't quite build up as much. So that's why there's a little bit of that net loss as we get older. And so medications like bisphosphonates slow down that breakdown of bone. And sometimes our bones are able to build up a little bit and catch up a little bit. And then there we have the medications like the abaloparatide, the Tymlos, or the Forteo teriparatide, and that can help stimulate new bone growth. So that's helpful as well. And then we think that with the exercise, with the muscles tugging on the bones, and that's also helping to stimulate the bones. But again, it's really hard to have any exercise program show that there's a fracture reduction, mostly because it would take a long time to show a fracture reduction with an exercise program, and patients would have to stick with that exercise program for a long period of time. And then in most cases, what I'll say is if my patients get enough calcium, vitamin D, and exercise, typically the most I hope for is a stabilization of your bone density, which again would be really good when we're expected to continue to lose bone as we get older. So just even stabilizing your bone density with calcium, vitamin D, and exercise, I think is a good goal there.
And
I imagine that part of the benefit too is to prevent the falls in the first place.
Absolutely. Yeah, and that's why we do recommend like a lot of times if I have patients who have fallen, I recommend physical therapy to help work on their core strength and balance.
Along the lines of the exercise, there's a couple questions here, and one is about the biodensity machine to improve spinal osteopenia and other exercises specifically for vertebral or spinal osteopenia. Do you know if that's actually, it sounds like it hasn't been proven for all the reasons you said, it's just hard to show these things, but do you know anything about that biodensity machine?
But is that like a vibrating platform? Because I know there's been some vibrating platforms that patients have tried to see if that would help improve their bone density.
I think this person says they've gained 4 pounds of muscle mass, so it's probably beyond that. It might be one of those isometric exercises. If the person who put that in wants to elaborate, throw that in the Q&A. But tell us about those vibrating. That always seems like an easy way to get some benefits without sweating a lot. Kind of cheating.
Yeah, I think there's some data behind it, not a lot of great data. I don't know how expensive these things are, but generally, I don't think we need anything that fancy.
Okay.
Somebody has asked if there's known exercise classes that the Brigham or Foxborough offers. Do you know if there's any resources out there for osteopenic or porotic women to be exercising together?
I know there are classes out there that target the bones. So I don't know of any like offhand, but I do know that some of my patients do participate in those exercise programs that are targeted for the bone.
And the couple of the websites that you mentioned, the AmericanBoneHealth.org, and I think the other one was Onera, is that right?
Yes.
We can, people are asking also if they can get this written down and a copy of some of your slides that list the medicines. Is it okay afterwards if we
Oh,
can
sure, absolutely.
Okay.
Absolutely.
So for those of you who are enrolled afterwards, we're going to send out a little email that'll have not only the usual questionnaire survey about how this went, but also we'll give Dr. Chou's contact information because you are seeing new patients, and also some of these answered whatever questions that we don't get to. So
Perfect.
Worry not. All right, cool. So back to the exercise, sorry to harp on this, specifically for the vertebral and the spinal osteopenia or osteoporosis, are there specific exercises that help that?
So it's been shown that a well-rounded exercise program is probably best for the spine. So that includes, again, the weight bearing, the strength training, and then I would say balance exercises as well, mostly for fall prevention.
Okay.
Depending on how low your bone density is at the spine, though, you might want to be careful. So if your T-score is less than -3.0, I would say that you really want to avoid any heavy lifting, particularly lifting over your head. Yeah, so that when you lift over your head, that puts a lot of pressure along the spine, and I'd be worried about triggering a compression fracture that way. And similarly, if your T-score is less than -3.0, I wouldn't start golfing just because that twisting motion of the spine can also trigger a compression fracture.
Okay, so those are the things to really avoid, would be the super twisting, the heavy lifting over the head.
Particularly over the head,
with the
exactly.
spine. Okay, that's good to know. And just for everyone who isn't naturally good at statistics and math, as I am not, the lower the T-score, the worse it is. I mean, the higher the T-score, the higher that.
The more negative the T-score, the worse it is.
So -3 is worse than -2.
Yes.
Farther you get from a 30-year-old, the worse you are. Okay.
Yes.
Got it. All right, Allison, you go.
Yeah, let's talk a little more about supplements and what you commonly just recommend, because I know you had great slides about the calcium and the vitamin D. We do have a number of patients that are proton pump inhibitor and have problems with acid reflux. Just again, give us a good summary about how we should be approaching this.
Yep. So again, for most of my patients with osteoporosis, they're usually postmenopausal women. I recommend 1,200 milligrams of calcium from diet and supplements combined. And my general rule of thumb is if you're able to get 3 to 4 servings of dairy per day, so 1 cup of milk, 1 cup of yogurt, or about 1.5 ounces of cheese, you don't need to take any calcium supplements. And so for patients who get 1 to 2 servings of dairy per day, I recommend a calcium supplement of 500 to 600 milligrams per day. Or if they aren't able to get any dairy at all, a calcium supplement of 500, 600 twice a day. And then keep in mind, we also have a lot of almond milks that are very popular these days. Most of the almond milks, most of the brands of almond milk are fortified in calcium. So for example, Almond Breeze or Silk, they usually have 450 milligrams of calcium per cup of almond milk. And so you can use that as a replacement for a calcium supplement. And now in terms of the calcium supplements, again, if you're on a proton pump inhibitor, such as omeprazole, or on an H2 blocker like famotidine or Pepcid, calcium citrate is better absorbed if you're on those medications. Keep in mind, most of the calcium citrate supplements, if you look at the serving size, it's actually 2 pills and not 1 pill. So if you're taking a calcium citrate, just know how many pills are in a serving size and then how much calcium is in that serving size. Otherwise, if you're not taking a proton pump inhibitor, then calcium carbonate is just fine for you. And the nice thing about the calcium carbonate is all it takes is 1 pill as a serving size. So instead of 2 pills, it's just 1 pill.
Great. And Metamucil, sorry, go ahead.
Go ahead.
Mylanta and Tums, not Mylanta, Tums is calcium carbonate, right?
Tums is calcium carbonate. Yep. So if you are taking Tums anyways for heartburn, that counts towards your calcium intake. And just keep in mind, it says Tums, like I think extra strength Tums might be 1,000 milligrams or something like that. That's 1,000 milligrams is a calcium carbonate, but it's actually only 400 milligrams of just calcium.
Oh, okay. Okay, good to know.
So there's another question about strontium supplements.
Yes.
What's your approach to using these?
So this is my spiel for strontium supplements. So the strontium that is approved for osteoporosis treatment in Europe is strontium rhenylate. That's different than the strontium that you get over the counter in supplements in the US here. So the strontium that's in the supplements available here has not been shown to reduce fracture risk. The other thing about the strontium that is approved in Europe is it was almost pulled off the market a few years ago because of concerns of cardiovascular events. So they didn't find that and they left it on the market, but that was one of the concerns there is the risk of cardiovascular events. And then the last thing I will say about strontium is a heavier metal than calcium. So strontium will increase your bone density, but we don't know if that increase in bone density actually reduces your fracture risk, at least for the strontium supplements that are available in the US.
Do you know if those trials are being done? Or
I I don't know actually, to be honest, if those for the supplement strontium. Yeah, no, I don't know. I'm not sure.
There's so much unknown in the supplement world. You know, when we talk about supplements, I think we really try to make sure that first we do no harm, right?
Correct.
And then if there is a potential benefit, we're reaping it. The other thing that we sometimes use is vitamin K2 with vitamin D. What are your thoughts on this?
Yes. So the thought behind using vitamin K in addition to vitamin D is that the K will help get the calcium to the bones and away from, say, the arterial walls. So it's more of a theoretical thing at this point, but we don't have a lot of great data that shows that vitamin K actually reduces fractures.
Got it. Yeah. So, you know, there's some evidence out there that has tied eating calcium supplements or taking calcium supplements to having more calcification of your heart arteries. So Dara and I have talked about this in the past, and there's no randomized trials to say it's bad, but it does seem like it's better to get it from your food. So we really try to encourage our patients to get it from their diet. Obviously, if you have had a fracture, you're really high risk. That's a different, scenario. But I know Dara has me drinking my smoothie, so I've been, actually tallying up, the amount of calcium I can get in there. So I think it's nice to think about it in those terms, right? How can our diet really be supporting what our general health goals are? And this is I think a great example of that, especially when we're really looking, to the future, right? And we're talking about how we want to be living, a decade, 2 decades, from now. So
absolutely,
this is great. Yeah, thank you.
Although I have a question, it starts to blur, the lines blur about supplement versus diet if you're talking about something like almond milk or tofu it's added. I mean, what is really the difference between getting it from your diet versus getting it from a supplement other than this large bolus all at once of getting 600 milligrams? Would it be just as bad if you drank 4 glasses of milk all at once or took, a calcium supplement? Maybe it's the speed at which the calcium rises in your body and your kidneys can't process it quickly enough. Is that probably the thinking of why it's a problem?
Yeah, it's hard to know for sure. I mean, I think if you have it from your diet, it's slowly absorbed over time along with your other foods. And maybe that would mean that a fortified almond milk might be better than a calcium supplement all at once if you're taking it with other foods to slow down the absorption.
Yeah, no,
I don't think we really know like what is better. And
right. I mean, in theory, I suppose if your calcium levels were sort of roller coastering and really high, that might be when not only are you getting it in your bones, but it's circulating for longer and maybe depositing at that point in your arteries and valves, as opposed to sort of a steadier state. Who knows, right?
Yeah.
Okay.
And there's just one other question that came up about the vitamin K and blood thinners. So I did want to just clarify, if you are taking Coumadin or warfarin, we do try to avoid those, but the newer blood thinners are not affected by K2. So if you're taking that with your vitamin D, it's totally safe.
Absolutely. Very important point.
Okay. Now, I think this is probably going to be a yes, but if you're on something like Fosamax, the calcium recommendations are the same, right? It's
absolutely.
okay.
And all those clinical trials with Fosamax, they were always Fosamax with enough calcium and vitamin D compared to a placebo group with calcium and vitamin D.
Okay.
So the Fosamax is the benefit on top of calcium and vitamin D.
Okay, great. And someone's asking a question about yoga twisting. So the twisting in golf, is that different than the twisting if you were supporting your weight with your arms?
Yeah, I think what I generally tell my patients is that, if you've been practicing yoga for a long time and you're doing it properly, then I'm absolutely fine that you continue with it. And I do prefer like the slower movements to the the very rapid twisting motions.
Okay. Safer. Okay, good. Yeah, go ahead.
There is a question about dental work, and I think because of everybody's heard, that connection is probably worth clarifying, right? So if you're taking medication and you're looking at having dental work done or having implants put in? How should we be thinking about this?
Yeah. So most of the time, if you're on a Lundronate or Zitronate, these once a week pills or once a month pills, and you're getting an extraction or an implant, your dentist may ask you to stop it for a couple months ahead of time. And I'm all for that. Go ahead and stop it. And I generally have my patients restart it 3 months after their extraction or 3 months after their implant. Now, obviously, if you're getting an IV infusion, it's very difficult to do that. If it's an emergency, I tell my patients, go ahead and get it done if it's an emergency. But if there's any ability to kind of postpone that invasive dental work as long as possible, I do recommend doing that. And then for my patients with on the denosumab injections, the Prolia injections, what I recommend is that they get their dental work 4 or 5 months after their last injection, when that particular medication is already wearing out. But in general, there's no issues, again, with regular dental cleanings, with fillings, with crown work, or with even root canals.
Okay.
And in general, with my patients on osteoporosis medication, I do recommend regular dental checkups and dental care just to make sure that their teeth stay healthy.
Great.
So you were talking about periodic DEXA scans, which are very low radiation, to monitor how you're doing either on or off these medications. Is there any role for any blood markers in diagnosing or treating osteoporosis?
Yeah, so right now there's no role in blood markers for diagnosing osteoporosis. There are some blood tests that can measure how quickly your bones are breaking down or building up. And so these are markers of bone resorption or bone formation. Generally, they're probably not as, they probably aren't as good as a bone density scan, but as we know, some insurance companies only pay for the bone density scan every 2 years. And sometimes I will use these blood test markers just to make sure that the medications are working. So the best way to use these these blood test markers is to get a baseline marker, blood test marker, and then start the medication. And then you can repeat the blood test about 3 months afterwards, just to make sure that you're heading in the right direction. Because otherwise, for a bone density scan, you would have to wait a whole year. Now, most of my participants, or most of my patients, really don't necessarily need to have these blood markers done. I do use them in patients, for example, with celiac disease, but they have pretty well controlled celiac disease. You know, they're very good about their gluten-free diet, but I'm a little bit concerned how well they're absorbing a pill medication like alendronate. So in that case, I generally will do it just to make sure that the pill is actually getting into their system and working.
Perfect. That makes sense.
That's great. So this has been very informative today. Any parting words of advice for our audience as we're kind of summarizing and wrapping up today?
Not really. Just that the ultimate goal for osteoporosis prevention and treatment is just that you stay as active for as long as possible and to enjoy your life however you want to live it.
That's wonderful. Thank you so
Perfect.
much.
You're
welcome.
So much. So we got to almost all our questions. So we'll take a look and see if there's anything we missed and circulate that to everybody afterwards. And Sharon, I just want to thank you so much. I think you'll be bombarded with new patients after this, but I know that you can handle it. So I want to thank all our participants as well. Thank you so much for your engagement and your great questions. And I hope we'll see you next on October 17th. That's our next webinar with Dr. Beth Freites. And she is the current president of the American College of Lifestyle Medicine. And she's going to give a talk called Working Toward a Healthy Body, a Peaceful Mind, and a Joyful Heart. So hope to see you all next month. And thanks again, Sharon.
Thanks, everybody.
Thank you.